Sawadee. Good afternoon, committee and participants. My name is Wadee Sukontasing, the student of the Aesthetic and Implant Dentistry Department, Faculty of Dentistry, Chulalongkorn University, together with my advisor, Professor Ajahn Pornchai, and Assistant Professor Ajahn Picha. I would like to present my proceeding in the topic of a radiographic study of mandibular incisive canal in Thais using cone beam computed tomography. Here is the scope that I will present about in the whole session. Start with the introduction. The common complications after the surgical intervention on the interforaminal regions are edema, hematomas, the loss of teeth sensation, sensory disturbance on the lower lip, and even fatal sublingual hematoma. As in the picture from Dental Research Journal shows severe hematoma of the tongue and floor of the mouth. The degree of nerve injuries varies from mild prior anesthesia to complete anesthesia. It could be either temporary or permanent. Unlike nerve injuries that result of other oral surgical procedures, which tend to be mostly temporary, implant-related nerve injuries are typically permanent, as in the study conducted by Libersa and colleagues. The picture shows a case demonstration of a patient who had complete anesthesia after implant placement in the lower right edentulous area. Picture A represents a post-operative of the panoramic radiograph, shows the implant superior to the inferior alveolar canal, while in the picture B, the CT scan showed that there was a radiolucency inferior to the implant through the inferior alveolar canal and approaching the inferior border. Direct contact of an implant with this structure can lead to migration of the soft tissue around the implant, preventing osseointegration and may cause sensory disturbance and bleeding in this region, so that the importance of the location of the incisive canal should be highlighted. Focusing on the dental implant, this retrospective clinical study was to evaluate the risk of neuropathic pain caused by implant placement in the interforaminal region of the mandible. Total of 19 implants in 10 patients were placed in the interforaminal region. Neuropathic pain was found in 8 patients. This picture representing perforation of the MIC after insertion of the implants. Another study from Wismeijer also found at least one MIC perforation by an implant and caused discomfort on the patients. Kohavi and Basif describe a case which pain and discomfort occur after the insertion implants in the interforaminal region of the mandible, and the CBCT images show that the implants were placed in the MIC. The mental foramen contains the mental nerve and vessel is located below the interval between the premolar teeth or the second premolar. However, the variation in the location of the foramen have been reported. The data from various ethnic groups, for example, Chinese and British, Brazilian, and African, show that the location of the mental foramen are varied by ethnicity. Apin Smith and colleagues studied specifically the location of mental foramen in Thais, found that the majority of the mental foramen were located in the same vertical line with the long axis of the lower second premolar. About the anterior loop of the mental foramen. According to a glossary of implant dentistry, the anterior loop is referred to as an extension of the inferior alveolar nerve anterior to the mental nerve before exiting the canal. The researchers also stated that there were a lot of variation found in the prevalence, length, gender, and size distribution of the anterior loop in various populations. About the mandibular incisive canal. Olivier was the first who defined the mandibular incisive nerve as a terminal branch of the inferior alveolar nerve, which extends anteriorly and medially to the mental foramen. The mandibular incisive canal represents the final branch of the inferior alveolar nerve and resides along with vessel in the incisive canal. The MIC innervates the lower anterior teeth, the intraosseous space, and the gum in the anterior segment of the mandible. The study to assess and compare the visibility of the MIC using CBCT and panoramic radiography from 486 hemimandibles, the MIC was visible in 51.2% in panoramic radiographs and 94.4% CBCT images. Because panoramic and other two-dimensional radiographic methods fail to show the buccolingual aspect, the visibility of the MIC in CBCT is much better than the conventional panoramic radiograph. Even some large MICs still couldn't be seen in panoramic radiographs. Saman and colleagues stated that the detection of the MIC using CBCT is crucial for surgical procedures involving the interforaminal region. The objective of the study was to assess the appearance, size, and cost of the mandibular incisive canal, which is MIC, using cone beam computed tomography in Thais. The research methodology. This retrospective cross-sectional study was conducted on 149 patients who presented for CBCT at Department of Aesthetic and Implant, Faculty of Dentistry, Chulalongkorn University. The inclusion criteria were Thai patient with age more than 20 years old who presented to the clinic for CBCT scan with all the teeth present in the interforaminal region. The patient without any pathologic disease or trauma and also without history of surgical in the interforaminal area. Exclusion criteria were edentulous patient or the patients with history of trauma or systematic disease that affecting the bone or pathologic that can affect the measurement, patient with severe crowding of anterior teeth or patient wearing fixed orthodontic treatment at the time of the X-ray, and also a patient with history of orthodontic surgery or genioplasty were excluded. Another 149 patients randomly selected, the sample be divided by anatomical site into left and right side of the both sexes, so they were independently measured. The patients were randomized, categorized by sex and also by age. The participant that fits all the criteria or the image will be measured separately to measure the diameter at the origin of the nerve and measure the length. The CBCT scan were obtained for all of the subjects by the same professional dental technologists following a standardized protocol with the same machine. All CBCT images were acquired by iCAD scanner and the com files. Measurements was made by the digital ruler included in the iCAD software. Appropriate background lighting and a computer Intel screen were used for analysis the image. One reviewer was examined in the image under the close supervision of an experienced radiologist and an oral and maxillosurgeon. For each scan, axial slices were reconstructed to be parallel to the inferior border of the mandible. Then reformatted panoramic images were made by creating panoramic curves along the arc. Cross-sectional slice perpendicular to the reformatted panoramic view. The anterior border of the mental foramen was identified on the axial view. White arrows show that the anterior border of the mental foramen. In case of the anterior loop located mesially to the mental foramen, the most anterior part of the anterior loop would consider as the origin of mandibular incisive canal. Both sides of MIC were assessed to examine all the variables. Cross-sectional image will be created with 1.25 millimeters thickness and 1.25 millimeters interval spacing. The diameter of the MIC at origin was measured by the mean value of each vertical and horizontal diameter in the vertical cross-section as in line 1 and line 2 in the CT and B and seen on the illustrator pictures. The posterior border of the MIC, which appears as a sudden reduction in the width, considered as the terminal point of the canal. The length of the MIC were measured by counting the number of the consecutive vertical cross-sections from the anterior border of the mental foramen to the posterior border of the MIC until it disappears separately as in the picture. The result of the study. The CBCT scan of 149 subjects consists of 78 males and 21 females were included in this study. The age distribution pattern of the patients was shown in the table. The age range was 21 to 73 years old. Mean age was 47. Age was normally distributed in both male and female. There was no statistically significant difference in proportion between sex and age range. From the CBCT of 149 subjects, the MIC was identified in 91.3% of all the images, found in 67 males, which is 85.93%, and found in 68 female, which is 97.2%. The mean horizontal diameter was 1.74 millimeter, 1.85 in male, and 1.52 in female. The mean vertical diameter was 1.73 millimeter, 1.88 in male, and 1.57 in female. The total length of the MIC was 7.78 millimeter and in male were 8.44 and 7.11 millimeter in female. In conclusion, female show less value than male in all the three variables. Mann-Whitney U-test was used to compare the measurement between males and females. Significant level was set at P less than 0.5. Results show statistically significant difference between male and female in all variables. Good intra-observer reliability was achieved with ICC, show good agreement for the diameter and length of the canal, ICC value 0.8. The discussion will be in three aspects: the prevalence, the diameter, and also the length. Start with the prevalence. The MIC was first investigated in 1928. Since then, many studies have shown the MIC to be consistent finding in cadavers. After decades, CBCT has been used to identify anatomical structures throughout the world, including the MIC. Because of the MIC show less bony corticalization and the diameter is so small, the conventional radiography often fails to display the MIC. In this study, the MIC was identified in 91.3% of all the images. The reported similar with Mitch and Crawford, Apostolakis, and Jacobs, who discovered 93% of the MIC on CBCT, while Pires discovered 83%. On the other hand, the MIC was found in all subjects in the study by Su, Mardinger, Kong, and also Al-Ani. In this present study, the MIC were identified in 67 cases, which is 85.93% from 78 males, and 68 cases from 71 female, which is 97%. The MIC were identified bilaterally in all cases according to the previous studies, similar to the current finding. Other studies have found that the tendency of the MIC was higher in female than males, which is in accordance with many studies by Pires and colleagues, Jacob et al., and also Apostolakis and Brown. Focusing on the diameter, the attempt to identify the incidence and characteristics of MIC have been done by many methods. Anatomical studies have been used to determine the diameter and length of the incisive canal. The mean diameter of 47 cadavers was 1.3 millimeters, according to Baritz et al. Maraiwa also measured that the diameter in 50 adult cadavers found it to be 1.8 millimeters. Also, 80 formalin-fixed semi-mandible of Chinese adult cadaver were studied by Su and revealed a diameter of 1.76 millimeters. When CBCT was brought to the dental medicine, it is more convenient and precise to identify the MIC than two-dimensional radiographs. From the study by Pioneer, 192 CBCT heavy mandible, the mean diameter were 1.47 millimeter, which is in accordance to this study. Also correspond to the previous result, the mean diameter being 1.1 millimeter from the study by Jacobs and colleagues. The length. From the CB study, Pires and Apostolakis determined the mean length of the MIC to be 7 millimeters and 8.9 millimeters respectively, while Marquis determined a mean length of 15.13 millimeters. The mean length observed in the present study is shorter, which may have been caused by a number of factors. The first one, the method used to identify the canal required its almost continuous existence to avoid mistaking it for other canals in the area. Since it has been shown that a number of canals enter the lingual cortex of the mandible to run an intraosseous course. Second, The length of the anterior loop was taken into consideration in this study, which reduced the mean length of the incisive canal. Third, it appears that a canal was not found in a minor percentage of cases, which is 8% in this study. This could be due to the fact that the incisive canal can appear as a labyrinth of intertrabecular spaces containing neurovascular bundles. In these circumstances, the incisive canal length was considered to be 0 and was factored into the mean length calculation. The study limitation, firstly, the number of the samples that could be included were limited to strict inclusion criteria. More samples may help to validate the result. Secondly, one observer explore other images. Another observer with more experience in viewing CBCT should be added in the future study to assess inter-observer agreement. In conclusion, considering the broad variation in the MIC data among populations, the current study may act as an anatomical reference data of Thai population that will be useful to achieve optimal preoperative implant planning. Thank you, อาจารย์ Pranchai and also อาจารย์ Picha ค่ะ ขอบคุณ
Okay, thank you so much for your nice presentations and all the background and discussions. That's really nice and in very detailed. So any questions from the floor? No? It might be because of your clear presentations. But anyway, I have one for you. So before we end, I would like to ask from do you think from your results, it seems like our incisive canal in Thai, they have very small diameters. Is that right?
Yes.
So do you have any review that the small size incisive canal will cause any complications?
The smallest one that caused the problem to the implants would be the study, I cannot remember the name, but the diameter would be around 1.8 millimeters. That it inhibits the osseointegration to the implants.
Okay, so we still have to be aware, even though the diameter is so small. Okay, that's very nice. One more question is on my own curiosity. So I really want to know the locations in buccolingual positions. Where did you often find the locations of the incisive canal? Is in buccal, middle, or in lingual?
Yes, in further study, I already measured that, and it's more in buccal area, which is inconsistent with another study.
Okay, thank you so much for your informative presentations. That was very nice. So now it's time. I would like to invite the next group.